I'm going to introduce the moderator from panel and the co-host of this event, Dr. Tonya Fancher, who is a professor of internal medicine and the division chief of general internal medicine here at UC Davis Health, and also the co-sponsor and co-planner of this event with me. So thank you so much, Tonya, and please take it away.
Thank you. Thank you, Courtney. I'm so happy to be here on behalf of general internal medicine, and really hearing all the discussion about primary care just really rings true with my heart, so thank you for that. I also want to thank the secretary for helping me to rename this panel. It is now called Reclaiming Our Profession and Science. And so let me welcome my fellow panelists here. First, Dr. Amy Barnhorst. Amy is please come on up, have a seat, turn on your microphone. Amy is a psychiatrist who's working in the Department of Emergency Medicine and runs the California Firearm Violence Research Center. Next, I'm happy to welcome Beth Magnan. Beth is a professor in the Department of Family and Community Medicine here at UC Davis. And next, you heard her name already. Let me introduce Carolina Reyes. Oh, can you get out of that? That's the hardest chair to get out of. You are so brave. I'm very impressed. Dr. Reyes is a maternal family medicine physician in the Department of Obstetrics and Gynecology here at UC Davis. And then finally, Dr. Anchi Su, who is here with us from the California Health Benefits Review Program. Thank you for being here. So I'm going to start with a few questions, and then we'll leave plenty of time for folks to ask questions too. So here's my first question. The challenge is to answer in a pithy way. Okay, okay. So who do you want to go first? Anybody. Okay. So we'll use this as the introduction for you guys to really introduce yourselves to the audience. And tell us about a topic that for you has received the most buzz, was the most discussed topic or product, and why you think that was the case. So who's feeling particularly pithy? Okay, Amy, please.
I'm not even sure I know what pithy means, but I guess I'll start because I'm
that
on
was
the end.
That was the challenge.
I would say the topic for me that received the most buzz, I'm a psychiatrist. I only do inpatient and emergency work, so no clinic appointments, no couch. I see patients who are seriously mentally ill, many of whom are homeless, many of whom are on involuntary holds, many of whom have substance use disorders and have been determined to be a danger to themselves or somebody else. And so they're brought in either to the ER or to an inpatient psych hospital for an evaluation and potentially for treatment. And I got involved with policy more from a clinician perspective because after a number of the mass shootings that had happened in this country, we started to see an uptick in kids and young adults who had made threats or posted concerning things on Instagram or come to the attention of the authorities as being possibly danger of mass violence. So they would bring them into the psych hospital, and I would evaluate them and oftentimes be like, I don't really know if I can do anything for this person. Yes, I think they're dangerous, but I don't know that the mental health system is the fix. So I got involved in policy that I'll probably talk about a little later, that our country's red flag laws that in California are known as a gun violence restraining order. And that they became very popular laws because when a horrible mass shooting would happen, it was actually like something you could do as a policymaker or a politician that could potentially address that mass shooting. So they got a lot of buzz because it was actually like the one tangible potential constructive piece of policy to help prevent mass shootings. And I had a piece in the New York Times that was just very randomly well-timed. I think it had been rejected numerous times before that, but it was published right after Parkland, and it talked about how the mental health system is really not the best place for these young men mostly, and how we needed other things to address mass shootings rather than trying to round up all the young men who have posted pictures of themselves on their Instagram holding semi-automatic weapons, rather than bringing them all into mental health care, which maybe they needed, maybe they didn't, that we needed other ways to address mass shootings. And I think that was part of why it got so much buzz.
And Amy, maybe for those who are unfamiliar with the red flag laws, can you just give a quick summary of what that means?
Yeah, sorry. So the red flag law is a law that we passed here in California in 2014, and we were really the first state to pass it in its most popular iteration, which is an order that allows for family members and law enforcement, and now in California, some other petitioners as well, to petition a court to get an order to remove somebody's firearms and ammunition if they're perceived to be a danger to themselves or someone else, and to prevent them from buying more guns. So somebody who is a legal firearm owner, who bought all their guns legally, who has no criminal record, who has no other prohibitory history, if they're determined to be dangerous, like for example, they're making threats to shoot up their school or their workplace, these various petitioners can get an order from a court to remove the guns that they have and put an order in place to prevent them from buying more. And we have now seen these laws passed, I think, in 19 states and the District of Columbia, including states like Florida, who traditionally have not been super pro-firearm law.
Hi, everyone. Well, what comes to mind for me with that question is a potential bill that I worked on with the California Health Benefits Review Program that was on coverage of fertility treatments. So we called it the IVF bill. And that bill came and we did an analysis, and then it came back and we did another analysis, and it came back and we did another analysis. And each iteration had a small change, and then the argument and the buzz around it seemed to be, how much would this actually cost? How many people would actually use the service, and then how much it would cost from that, and who should have access to the service and in what way. So it was a lot of different tweaking, and people sort of on both sides of the voting platform or advocacy for it, making adjustments or making arguments, and then us having to have the position of, this is what the evidence shows, this is what the evidence doesn't show, this is how we interpret the evidence that you're telling us says something, but we don't think that's what it actually says.
I'll want to hear more about that part, that part too. Okay. Carolina, please.
I think some of the most striking statistics for me are that 3 women die a day in hospitals that are delivering, pregnant women who die a day, and one every 5 days in California. And about 60, and depending on statistics, up to 80% of those deaths are preventable. And that's really been much of my work over the last, 15 or so years in trying to identify, because really as maternal fetal medicine specialists, as obstetricians, we're in hospital settings and trying to make sure that we have the best standard of care. So it's hard sometimes for those practitioners to say, what are we doing? What can we be doing better? And so over these last 15 or so years, have really made an effort to try to reduce the preventable maternal deaths in many ways. And I think we can talk about those things. But for me, that is the driving force around what is preventable in the quality of care that we provide.
Wow. Thank you.
It's hard to follow up.
It's hard to go last. Yeah.
So I work with Beth at the California Health Benefits Review Program, as we affectionately call CHBRP, an unfortunate acronym, but memorable. And so we look at a lot of different topics, and it's all what's interested, what the elected officials are interested in. So this year, besides IVF, one of the other topics that came up and has come up multiple times is GLP-1s. It's everywhere. If you're not talking about HR1 or something else in healthcare, you're talking about GLP-1s. And it's a huge topic in healthcare. It affects a lot of Americans, and I think at least, so at CHBRP, our job is to analyze proposed legislation from the legislature to talk about the impacts in a neutral, nonpartisan way. And so legislators, when they propose bills, they're interested in helping their constituents. And so I think GLP-1s are people want to understand more, people want coverage for them, and so that's what they ended up bringing forward a few times.
That is a hot topic nationally as well. Just given that introduction, I want to just pause for a moment to see if anyone has questions for this group, and otherwise I will continue with my questions. Okay. Carolina, I'm going to go back to you and really ask you to help us think about exactly what you're talking about. So California, particularly in rural hospitals, we're really seeing the access to care and lots of closures and the concern for the real impact that's going to have. So how can folks like us really be part of that conversation and the policy decision making?
Well, I think I would start from what we define as quality of care in a hospital setting and make sure that we have a standard of care that's that then the hospital systems can try to provide. And this is across the board. I mean, this is whether you're at your tertiary care centers or in rural health. Because I think we find that there's room for improvement, even though we think we're at our best, that there's room for improvement. And unless you know how to measure things and you over time look at your changes, you're not going to know whether you're making progress. You just think you're doing the best you can. And so for us, it's about, there are a couple of challenges here. One is trying to make sure that we are trying to address things that are, as I say, preventable in hospitalizations, and also trying to make sure that the providers have the right training, simulation trainings, as well as resources around them so that they're well supported as they're providing the care. We have tremendous challenges, not just in hospital systems to keep up with that quality of care, but especially with rural health systems. And I have to say, here at Davis, we have these collaboratives, we have these regions, right, where hospital systems are in touch with UC Davis as a tertiary care center when they can only provide so much care and the patient needs to be transferred. So for us, it's having that level of communication and access that patients here at Davis come from the borders of Nevada to the borders of Oregon, along the coast, all the way down to this area. And so it's making sure that they have the right resources. We are in a quandary right now because rural health systems do not have that level of support. And the $1 trillion deficit certainly, or changes, is going to impact those rural hospitals more. So it's a question of what can we do collectively as a state to help support them, at least provide a level of care that can provide basic care that, again, for things that are preventable. It's a real challenge. I think for us as researchers, and it's providing the data and providing the trends. I've really relied on that in terms of helping then decide, okay, what's clinically relevant, and then how is it that we can impact policy? And so we rely on that level of data, whether it's mapping, whether it's at the individual clinical level, to help support our sort of advocacy work in terms of trying to have our legislators and other policymakers provide the right resources for places like this.
Sounds like it's a difficult one.
It's something that we just as researchers, as those that want to impact policy, is to help provide data that is useful, right, and that is valid, that can then be translated into what does this mean in terms of where we put our dollars. And I think I've learned over time of somebody who wanted to help improve the quality of care, that the lingo or the language, as you heard from Javier, the language for policymakers is very different than ours. We can provide them a lot of data, but it's like, okay, what does this mean? And I think that that's where we can then try to be a little bit better at explaining it in a way that then helps them translate it to where can we place dollars.
Anchi, I wonder if I can follow up with that question for you. Can you help us to you sort of sit at the intersection, right, of speaking with scientists and physicians and then bringing that to policymakers. Tell us about what that interpretation or translation, what that process is.
It's very long. It's a different language. We kind of, at SHBRP, we kind of speak in Shabirpese a little bit because we're working with academics who are incredibly smart people. And what we tell our faculty members and our researchers is we have to think about it at like a 5th grade or 8th grade level. And the way that I like to, when I'm writing myself, I'm like, okay, if I was gonna tell my abuela what I do or what this policy does, how would I say it? Because we're talking about people who are smart, but they're not familiar with our research. They can understand data, but you have to present it in a way that is approachable. So one of the things that we're doing at SHBRP is not only focusing on, making the reports, which are very in-depth, detailed, in a language that people understand, but we're also trying to kind of like Secretary Becerra was talking about, meet people where they are and give them in formats that they understand too. Legislators, legislative staff, state agency staff, they don't have a lot of time. And they have so much, they have so many topics that they're thinking about every day, and it's not just health, it's not just the environment, it's not just electricity or whatever. They have a lot going on, and so if you can do it in a bite size, what are the 3 takeaways? If you were gonna have 10 minutes with that person, an elevator ride with that person, what's the one thing you want them to walk away? What are the 3 things you want to walk away with? But yeah, do it like you would have your grandmother. How would you tell them?
Brevity is not a strength in
No,
in this field. Yeah. Amy, that's a really nice segue to your. As I've known you, you've been very active on social media with your work, and so maybe you could talk about how social media has been helpful, maybe how it's been harmful, and ways that folks should really carefully think about social media, as Secretary Becerra also spoke to.
Yeah, I really appreciated that he said that because I have been surprised and actually, frankly, a little horrified by how powerful the voices of physicians and researchers and anybody else who has the internet can be on social media. I was really active on Twitter for a while, and I have to say I no longer am since Twitter has changed into other things, and it's not even really some ideological problem I have with it. I just sort of lost how the interface worked, and it wasn't fun anymore, and so I got off it. But there was a brief time where I had this really great community of other physicians and researchers and scientists on Twitter. It was great for professional connections. I learned so much, and I garnered a lot of followers. I was quite popular for a while. But ironically, I was popular because one of the things that went viral and got me thousands of followers was a post about my new mountain bike. So here I am, this voice of mental health care, sensible firearm policy, public health, but people are listening to me because I bought a bike in 2021. People are listening to me because I made a funny comment about, my kids and the pandemic. And suddenly I'm on all these lists of journalists because I didn't know this before, but this is how journalists find out who to call to get a quote about something important. They don't see who's published the most peer-reviewed papers or who has the best H-index. They go on Twitter and see who has the most followers. So it was great when they're coming to me and asking me things that I actually know things about, like civil commitment laws or serious mental illness and violence or gun violence restraining orders. But then they would also want to interview me for things like mRNA vaccines or childhood pneumonia. And I was like, oh my God, you really are, I'm the wrong girl for this. But if I had said yes, they would have just quoted me, And so it was a really interesting lesson to see how it is the loudest voice with the most followers, not the person with the most expertise. And I really have been meaning to get on TikTok or what are the kids are doing these days. It's a lot of work to figure out a new platform, and I haven't, but it really is such a powerful way to get the message out there. And unfortunately, that is where people get their information these days.
Can you share if you had any negative consequences of being so active on social media?
I did, of course I did. One was, there's a little sort of, you get in your echo chamber, right? And there's a discourse that goes on, and there's memes in the sense of the image you actually post, but then there's also just memes of discourse or sort of jokes that carry threads. If you are all on social media, you probably see people sort of repeating these same jokes or these same things. One example was I repeated there was a joke about something going on at the time, and so I had posted something in using that language instead of repeating the joke. And one of the trainees I work with, who clearly wasn't familiar with this, saw what I had written and thought it was a personal, actual thing that had happened, and really took offense that I guess thought I was talking about them or somebody in their program, and it got to be this very personalized. It was a total misunderstanding, but it was just the product of putting this information out there very publicly, which I had done, and having somebody close to me in my own town and my own program read it among the other 20, 50,000, whatever other people who saw it, and take it as a much smaller, more localized comment. And that was a really good wake-up call of like, oh yeah, I know some of these people personally, and they may think this is about our real life here, not the life out there in the sphere. And then there's also just things of like when my mountain bike post went viral, I panicked because I was like, it was a picture of me with my bike in the street. I'm like, oh my God, is my address on there? I had another incident where I posted about this. It was very strange. I had submitted a paper to a journal. They'd come back with a lot of edits. We'd gone back and forth a bunch. Ultimately, my co-author and I decided that it wasn't a good fit because we didn't like the edits that were being suggested. So we pulled the paper from the journal. And a few months later, the editors of the journal published the paper under their names. So I posted about this on Twitter. It was really, really bizarre, and that was the other thing that got me a ton of followers. Again, not because I'm an expert. For all my followers know, I made this whole thing up, which I didn't, but I mean, I could have. It was a very viral, popular story. The media picked it up, but all of a sudden, I had all these people who were just filled with vitriol and hatred and were ready to go hunt these guys down. And I had to start posting like, please don't dox them, please don't look them up. I had to remove a lot of the information, but it was a big deal. And I suddenly realized I didn't think how many people would see this, and now I've maybe put these two people and their families in danger. I mean, the Twitter mob they're for real.
What's that? I just said they're still there. Yeah, that's a horrifying story. And I keep thinking, Amy, when we were putting together this panel, I was thinking about when I wrote your letter for promotion to being a professor. Congratulations, yeah.
Thank you.
But so much of your dossier was non-traditional. So it brings me to the rest of the faculty on the panel, and to say, some of this work isn't really valued when it comes to promotion in this type of system. So Beth, as an earlier career faculty member, tell us how you think about that, how you weigh the benefits, and then how can we do a better job as faculty to support this work as really valuable to the academic enterprise?
That's a great question, and something that we've been grappling with at CHBRP as well, because it's really important work. I mean, it's important for our society, and I think what we do is really important in defense of science. I'd mentioned earlier with the IVF and companies wanting more IVF to be done, kind of cherry picking the data that they're using, where our approach is really this is all the data, and being neutral or being in defense of the science. And I know Anchi and I go back and forth a lot about how short it should be so people read it, but how long it should be so all the science can be there, and finding that balance. So scientifically, professionally, I think the work is really important. So that is what drives me to do it, more than the promotion or the merit packets and what it serves there. And I'm fortunate to have, support from my department to keep doing this type of work. But in terms of the, fruit of the realm, it brings in some funding, but it's not big grant dollars. It brings in some sort of publications. They're on the website, but they don't have a PMID. They're not they are peer reviewed, but not in the traditional sense. They don't have authorship in the traditional sense. So in terms of when you're counting the number of publications, all the bills that I've done aren't counted in that list, right? It's almost more of a service than it is a research type role we have. And I think it comes a little bit down to messaging too, of how do we message to other academics what it is that we're doing and why it matters and why we need to keep doing this. And I know for CHBRB, state law says that we have to do it. But for me in particular, why am I doing it and how are we serving others with what we do?
Does it feel like there's a cost to being an academic in that space?
I think there's a time and sleep cost. I know it gets really, really busy. Anchi said it takes a long time, but from an academic perspective, it's incredibly fast. It's a 60-day timeline from when we get the topic to when the final edited, fully formatted document has to be submitted, which is just unheard of for anyone who's tried to do a review or a systematic review. And I know I get caught up in clinic, which puts a 4 to 5 hour block on my time, and I feel badly holding the analysts back. If they send me something at 5 p.m. on a Monday, and I say, well, I can't get anything to you until the end of the day Tuesday because I have clinic in the morning and then I have faculty meetings, that doesn't seem right. So I will try to work Monday nights so that I can get something back to them to work in during the day. I don't know if there's been in academic progress delay, maybe. If I had taken a different path, maybe I would have more publications or grants, but I can't know what that path would look like, and I like the path I'm on.
Then it's really important, the path that you're on, and maybe we'll ask Tony later to help inform us. I was thinking about the IVF work that you talked about, and Anchi, I think I was also thinking about what Secretary Becerra said about equity and access, and that what we do really needs to be informed by giving people the opportunity, right, to have access. And as a workforce researcher, I think it's also access to a certain types of physicians, right? But tell us how are you able, or how do you think about equity and access from your standpoint when you are asked to think about something that's very expensive, GLPs, IVF, right?
Ooh, that's a good question. So one of the pieces of our statute actually asks for us to look at the social drivers of health and how how those impact the legislation and how it would be implemented. So we definitely do look at that. We also do disparities research, and just to kind of look at the problem, the challenge, the thing that the legislators are trying to solve from that perspective, just to give that background piece. We do look at things at a population health level in general when we talk about public health impacts. But we do often mention, hey, this would actually often, even if there isn't a very large overall population health impact, it could impact a very small number of people in a very big way. And that's a little bit harder. We try to stick with the facts in general, but we also want to give a complete picture. So we don't want to say, okay, these are the dollars and this is the cents. We also want to make sure that people understand that these are lives that we are talking about. One thing that we try really hard to do, though, in terms of our language is maintain that neutrality, so you won't see a lot of adjectives in our work. We don't say that there's a small impact. We just say what the impact would be. It would be this many lives. And that way, the legislators, the staff, whoever's reading our work can take that information and use it the way that they will. And so we basically say, okay, these are the disparities that are out there, and do with it what you will. This is what our projections are.
That's hard.
Yeah.
Yeah. Because I was thinking about what Courtney was talking about with the secretary about how do you message, right? So data is one thing, and then sort of how you share that message can have influence. So can you talk a little bit about that? I realize you don't use great or small, but maybe how do you select your top 3 points? Because I bet that there are many. And in that process of selection, how do you think about then the impact?
Great question. So we try to give, like I said, a complete picture of everything. And so our reports are much more in depth than what we might put on an infographic. But I think we want to take, we meet with a lot of stakeholders, to be honest, beforehand. So we will meet with the legislative committees, the health policy committees, the appropriations committees. We meet with a lot of staff members and state agencies. And so we have an idea, even the plans, the physicians, what their priorities are. And, for some stakeholders, we know that it's going to be cost. So they want to know what that bottom line dollar amount is. For consumer advocates, it might be something different. It's going to be like, okay, how many lives is this actually going to impact? And so meeting with stakeholders and kind of understanding what they want is really important in identifying what those top things are. But I think one thing for CHBRP that's really, really important is that we do maintain that neutrality. And even though we've had some topics that have been really challenging, I think, for our teams to use that neutral voice in, because they are heartstring issues. You are talking about, people come to you and they tell you about this very rare disease that their child has and how it's devastated their family. And we have to be the neutral one saying, well, this is what the cost is, whatever, et cetera. But if we do add a bias to our work, we lose the trust of the people who are using it. And I think that's really important for us to maintain that trust and be, telling what the facts are in a way so that people will actually come back to us with their trust of other issues that have additional bias. So.
That makes sense. That makes sense. And you're opening up a door that I hadn't really thought about. My impression was that policymakers come to you, right? But it sounds like there's different types of people perhaps are coming to you. So tell me a little bit more about this. I have a family member. I'm interested in this type of approach, or. Can you give us an example of that?
Yeah, absolutely. So when the legislature picks the topics that we look at, so we never choose any of the topics we look at. We also don't give any policy recommendations. That's kind of one of the unique things about CHBRP. But what we do is once a request comes in, there are 2 weeks from when that bill request is given to us that the public can solicit information, and we take all of that information, we read it, we will meet with people if they ask, and consider it in our report. Now, whether or not we use the data that they bring in our analysis is a different question. We have a very rigorous process and say, okay, this is the level and quality of the data that we want, and so we take that into account. But another thing that we do just to kind of make sure that we understand the intent of the legislation is meet with the office that has authored that legislation, and they'll often bring sponsors. And so that's typically when we see the folks who are coming in with like, hey, this is what's happening to me. And then we do the analysis after that.
Okay, thank you.
And if I can just add, we never give any recommendations of you should pass this or not pass this. And we do try to avoid numbers. We wouldn't say there are a small number of studies. We would just say there are 5 studies of 50 people each. But we do summarize for every type of outcome that we look at, potential outcome for like IVF might be live-born pregnancies. We do summarize the amount of evidence that's available. And we try to use labels for that summary that speak to what Courtney was saying. Do we know a lot or do we know a little? Like there's clear and convincing evidence, were the labels we used to use, that IVF works for live-born pregnancies. And then we do try to give some sort of clinical meaning for that. So for IVF, it has about a 50% success rate. And so let's talk about 50% success. Is that a lot? Is that a little? I think it depends what you're talking about. If you went from 0 chance of a baby to a 1 in 2 chance of a baby from this procedure, that feels like a lot. But maybe if you have a cancer diagnosis and it's 50%, there isn't, or there's a treatment that's 90% and this new treatment's 50, that's a different story for the 50. So we try to contextualize it as well as we're summarizing the data that we're getting and giving it meaning.
I like the clear and convincing. Are there other code words we should know, code phrases?
Well, sometimes we talk about conflicting. If there are 2 studies of kind of equal quality and one says it works and one says it doesn't work, or we can say limited evidence if there are only a few studies, they're smaller or they're lower quality. You know, we love RCTs. Sometimes RCTs aren't practical, like there aren't RCTs for IVF. But in somewhat of a way, you can kind of say that the large observational studies are. And so we'll look at the size of the studies, the type of methodology that was used, the quality of the methodology from what we read in the paper, and then summarize a like clear and convincing, a preponderance of evidence, limited evidence, insufficient evidence, or conflicting evidence.
See, you had a hierarchy. See?
Oh, we definitely have a hierarchy.
Yeah, yeah. This is a question that's more appropriate for Amy and Carolina. But the world is changing. The political climate is changing. And you guys have been in this work for a long time. How has the climate impacted, I love the idea that the language is ours to choose, right? And talk a little bit about whether or not, or how, the climate has impacted either how you think about these problems, how you talk about the problems.
There are probably 2 examples that I can give you, and I want to go back. I'm dating myself, but 20 years ago. Again, always feeling like in that same situation, climate's changing, et cetera. Sometimes those policy issues come to you, right? Or those questions come to you, and you need to find the evidence, or you need to figure it out because it's not been studied. So I think of issues like domestic violence, right? Where now it's pretty standard that we screen for domestic violence in the ER, certainly in women's health. That didn't used to be the case 20 years ago, when under the, even longer maybe, under the early part of the Clinton administration, there was dollars that were put into violence against women, Secretary's Act for HHS. And dollars were given to Agency for Healthcare Research and Quality, which had a different name then, and they didn't know what to do with it. They're like, we do use quality and utilization work. We don't deal with domestic violence. And our obstetricians were saying the same thing. Why should we ask this question if we don't know what to do with it? And somehow I found myself as being a scholar of the Agency for Healthcare Research and Quality at the time, and saying, can you help us with this as the obstetrician who understands the work of policy? And it was bringing together the obstetricians and the quality individuals and data people to come together to say, what can we do about this? And recognizing that even just screening for domestic violence was an interaction. I mean, it was an intervention, because at least women knew that somebody was listening or could understand. And I remember patients as an obstetrician then just asking the question, do you feel safe? Are you safe at home? Any violence at home? And they wouldn't answer the question then, but would come back subsequently months later and said, remember you asked me that question, I'm ready to talk now. So recognizing that that was an intervention. And just the small steps of incorporating domestic violence screening into our day-to-day work now took a couple of decades. And so I have found that sometimes these issues aren't really about one administration or another administration. It's really about where's the need with what we have, what can we do? And I think that that's how I've always tried to channel my energies. The other work I think we're going to talk about is the work that was really driven by Congress on this multiple studies already showing that there was a difference in how physicians treated patients, right? And race was a factor on how, with hypertensive patients, doctors would use one medication for some because they were African American and a different medication for others. And so if they were blinded by race, that the decision was more equal. And so it was Congress that finally mandated the Institute of Medicine to come together and say, look at these studies, what is real here? Because clearly, and this was early in my professional career, where I was asked to be on that committee on understanding healthcare differences based on race. And at the time, I thought, we don't treat people differently, and many on those committee really felt like, well, what's happening here with these studies, let's really understand. And it actually took months for that committee to finally come to the understanding after reading, there were like 400 articles or so, on these differences in care, mainly dealing with pain and other issues, that there was a difference. And that's where the unequal treatment report came out. And the unequal treatment report was really basically saying that, yes, we recognize that people are treated differently based on race. That was an epiphany then, 20 years ago or 22 years ago. And we thought this is going to revolutionize, how we as physicians treat patients. It was so much of an epiphany for us, but it didn't really change that. It was hard. Change is hard. And so it really didn't change much of the practice. The agencies started to produce then, the AHRQ, the Agency for Healthcare Research and Quality, started to produce a healthcare disparities report card on, okay, what are we going to measure to see, what is different? And that was a novel framework that had to come out. The cultural linguistic appropriate standards from HHS were started to be developed, again, because it's, do we ask the patient what's their language of choice, their preference, the way we speak to them? And then other types of measures around equity that finally took about 20 years to be incorporated into CMS. So some of these are driven really by the public that translate to legislation, that translate to dollars, and then they say, go figure it out. And so, and I think that's where I have found some of my work over these years, where it isn't about trying to stay so siloed in, because as a maternal fetal medicine specialist, it's very easy to stay siloed on a disease, right? It's more difficult to incorporate the other aspects of health, the other things that affect health, what we call the social determinants of health. Those things we have struggled to incorporate. And I think so when you ask the question about in this time period, how does this affect what we do? I almost feel like over these decades, it hasn't been about the administration that's been there. It's been about what do we think we need? How do we think outside of the box to incorporate those things so that now we define health in a much what's involved in health in a much broader perspective than we ever did. It didn't matter which party you were. It's just we we just didn't have that type of framework. And so what I say, as what Javier said, is that if anything, it's this time period when your budget's lower that you really have to think about what's important here and what do we need to focus on. And it's a time really when it's a time to step up, and it's a time to really then hone in on what's important. And I guess I would say it that way, because whichever party or whichever side, or even physicians or scientists that are very well-intentioned, sometimes we're too comfortable and we're too complacent in feeling that we only need to focus on in a very specific way, right? Helping drive the agenda. But the reality is it's these times that help us think broader and help us then refocus on what's important to us and what's required.
That's beautiful. Thank you. Good luck following that, Amy.
I'll say just briefly, I don't know that I have quite as inspiring of a story, but the one thing that I can think of, well, two things maybe that have changed in terms of the discourse and the language in my time doing this. I came into the work that I do through the portal of mental illness and firearm violence, particularly around mass shootings. And when I started, it was mostly because people were blaming mass shootings, Sandy Hook and others, and Columbine on mental health problems, blaming the mental health system, and really trying to figure out how do we bolster the mental health system so that that can be the mechanism by which we stop these things. And polls showed that at the time, the majority of Americans thought the failing mental health system and mental health problems were the cause of these mass shootings. And there was a big sort of groundswell of support and narrative change that involved people on Twitter, a group of policymakers I worked with in the Consortium for Risk-Based Firearm Policy, researchers here at UC Davis, media folk who were willing to listen to the new narrative. And I think altogether we were able to really change that narrative to focus on, firearm access among risky people rather than mental health issues. And now polls show that the public opinion has shifted by like 10 points. So it's been really cool to see that focus on mental illness and mass shootings moving more towards firearm access and mass shootings. And one of the things I'm working on now is I do a lot of work around suicide prevention, particularly with firearms. And there's been a movement in the last, I would say, 3 to 5 years of people who are doing firearm injury prevention work, really partnering with firearm owners, firearms instructors, gun shop owners, ranges, people who are within the firearms community, recognizing that we're never going to be a country that gets rid of all of our guns the way Australia has or other countries have. We're going to be a country that values our Second Amendment rights and has very high numbers of firearms. And so how do we work with that? How do we message to the communities impacted that sometimes having a gun in the home can be risky? We don't do that by, having this us and them mentality. Guns are bad, gun owners are bad. We're going to tell you how it should be. We do that by partnering with them, by making inroads, by having trusted messengers, by working within their systems and their people, and having the people that they trust, the firearms community, the people who are the most at risk of firearm suicide or other firearm injuries, having them be the ones who come up with the messaging, the messenger, the materials, and being really the ones to teach people where we, help provide some of the research and the policy and the data behind it, but really partnering with them rather than, I think alienating them, which has happened in the past.
Wow, it goes back to your C, right? And really, it's the people, and for you, it's sort of the coach equivalent, right? In what we heard about earlier. Let me see if there's anyone who has any questions for our panel. Yes.
Hi, thanks everybody. This is a question for the clinician researchers on the panel. And one of the powers that you have as being a clinician is you're often the only person in the policymaking space that has extended direct patient interaction and gets real people's perspectives on these issues that the legislative agency staff, research staff don't have that window, and that helps move, for example, that equity conversation. It's pretty obvious if you've worked with a patient experiencing inequity that that's a challenge, but it may not come out to an economist or an epidemiologist so obviously. So how do you balance that with your research communication to also be a patient advocate?
I can start on that one a little bit. I think that's a really good point, and as we heard earlier from Secretary Becerra and from Courtney, it's really human stories that people care about. I'm a researcher too, I'm a numbers person, and I'm always a little bit disheartened by how much people don't really care about the data. They care about the stories, right? When you read a news article about a really important policy or a new research study, they start with a story about a real person, and that's what everybody reads, and then they get to the numbers and they kind of gloss over it. And being a clinician gives me those stories, and it gives me I mean, it reminds me why I do this work too, because truthfully, the stories probably matter to me more than the data also. But when I, write an article about a policy, nobody cares about the, nuts and bolts of the data. They want to start off with the human story of the patient. I saw every single time. I mean, that is the template. And I think it's so valuable to be able to have those stories and share them because they really make an impact.
My role is a little bit different with CHBR because we're trying so hard to be neutral and not advocate for anything except for the evidence. But the patient stories come in on their own to the legislature. We are able to use my experience with the patients to understand where to look for the evidence and what type of evidence to look at. Because we look for benefits as well as harms, and we talk about what the possibilities are and how we should look at the evidence. The other part that I bring in from the clinical side is the health systems process. There's a lot of wishful thinking about things that we talk about of like, this will work this way, and then you'll do this and this. And I say, no, that's not how any of that will actually work. The MA will give the form will be left in the corner of the room until the end of the visit that was actually about something else, and then we'll look at it quickly, right? And so talking about realistically what's going to happen in a 20-minute visit. We did one on, fluoride brushing for dental work. Could that actually happen in primary care? Where is it happening? Why not? Really talking about the mechanics can help take things from a lofty ideal of what would happen to what really does happen in a busy ED, in a busy primary care setting.
I find that people are just very hungry for are always searching for accurate information. And so whether, for me, it's been in the community or even among professionals, there are always very specific questions that people tend to ask. May not be related to the topic I'm giving, but they come and they ask. And so to me, it's such a valuable, we really are in a very precious role as professionals who have information, to provide that information to those. And I became an obstetrician mainly because I really felt that if I could influence the mom and she influences her family, we can improve in their health. And so for me, it's always been extremely valuable to try to provide some of this information with the health education. I find whether it was in English or Spanish, we make every effort. I try to provide some of that. I'm not on social media, or at least I try not to be, but in various ways. I know the Center for Health Disparities here, that's run by Dr. Sergio Gaxiola Aguilar, has always brought me in to provide some of this educational material to those in English and Spanish. And so I find that there are others that invite us to do this. And so you ask, how do you do this? It's not on your academic time, right? You have to make time for this. But I think it drives me in terms of receiving that reward that people are more informed and to encourage them to then certainly use whatever information we give them to improve their health care.
Dr. Kravitz, yeah.
Hi, Rich Kravitz from UC Davis Division of General Medicine. I wonder about your views of how academia might be restructured. Secretary Becerra talked about giving policymakers options, and one thing that's really become clear from the discussion is that effectively disseminating evidence is not that easy. It requires skills, and one option would be to just keep going the way we're going. Another might be to form a completely new academic track focusing on science communication. Maybe a third would be to delegate these tasks to people who are good at them. You four are really the exceptions, let's face it, and the academic structures are not constructed in a way that really rewards or incentivizes these kinds of activities. So what do we do?
We do summits like this. I was really proud to see Davis host this type of summit so that you bring your legislators, you bring community folks, you bring your academicians to have a conversation about what's important. And I think it helps, certainly those that try to drive some of that science, helps gauge, it helps drive some of what we do. And so it's bringing collaborations like this together that is an incredible step.
I think that Davis has done a reasonably good job of supporting that because we're in Sacramento, because we have such a strong network with policymakers. Dr. Fancher mentioned that my promotion packet is somewhat non-traditional, and every time I submit it, I'm a little nervous and then surprised when things go well because, you know, I don't have that many peer-reviewed publications, but I have a lot of Twitter followers, and it's embarrassing, frankly, to put that in a promotion packet. But also, it means that, again, like I become part of the conversation around mental health and mental illness and our mental health care system in this country because I bought a mountain bike. But, you know, that's like, it matters, and that's part of my career is that I get to have a say in those things, and I really appreciate that. I feel like that has been valued in my department and in the medical school, and I'm very appreciative of that. And I hope that that continues because if we're just doing research in our little ivory tower, it doesn't matter at all. We're not making a difference. We have to be able to bring that out, and we have such a strong potential to make a big impact here, and I think we really do leverage that well for the most part, and I hope that we continue to support people who are doing non-traditional policy work.
I know we're short on time, so I'll add something brief. I think communication in science is really important, and I think partnering with people who are good at communication in science to help teach us and support us is a great idea. I also think it's really important for us to learn to speak everyone's vocabulary and learn that there are different vocabularies. I took a wonderful class during my Ph.D. that was co-taught by public health, a medical doctor who was in population health, and an engineer who did human factor engineering. And we got to have great conversations about how a word we use in medicine might mean something really different in engineering, or we might use a different word there to mean the same topic that we have in medicine, and that we all come with different perspectives. And I'll share right now, I'm on a journey with my daughter with learning disabilities, and the language that the educational people use is so different than the language I use, but we're saying the exact same thing when I look up the definitions. So as we start to learn that how to hear each other talk and how to understand what we're really saying and how to translate the vocabulary from one field to another, I think we can better start communicating our message and hearing the message from others.
Wow, fantastic. I know we're at the end of our time. I just want to thank each of you. It's really such an honor to sit here and to learn from each of you and for sharing all of your work with us today. Thank you very much.